Welcome. Thank you for joining us today. I'm Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General.
Hi everyone, my name is Shayna and I'm a grad student at the BU School of Public Health and I'm spending my summer interning here at the Blum Center. Joining us today we have guest speaker Dr. Christine Parsons. Dr. Parsons is a rheumatologist at MGH. She is in her second year of rheumatology fellowship. During her fellowship, she's focused on medical education and musculoskeletal ultrasound training. She's here today to give a talk on rheumatoid arthritis. Please join us in welcoming Dr. Parsons.
Thank you. Before we hand it over to Dr. Parsons, I do have a few housekeeping items to review, so let me go and do that first. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has been muted when you're a guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to complete. Your feedback is important to us as we plan future programs. All right, so next I'm going to turn it over to Dr. Parsons, who will get us started.
Thank you, and thank you for that kind introduction. I'm excited to be here today. Let me pull up my slides. And then I think everyone can see Dr. Bolster too is on the call, my our program director extraordinaire. So she'll kind of be precepting the talk with me as well. Okay, can you guys see everything? Okay, so today we'll be talking about rheumatoid arthritis and explaining the inflammation behind this disease. I don't have any disclosures to announce. So we'll be trying to cover a couple learning objectives today. We want to review who gets rheumatoid arthritis, what are the common symptoms, and what's the expected course of this condition. And we're going to highlight some key treatment strategies for people with rheumatoid arthritis. So rheumatoid arthritis is a chronic autoimmune disease. It affects the joints, but also other organs. It was first described really a very long time ago. Hippocrates first at least described an arthritis affecting younger patients, which is kind of different than the normal arthritis. And he said, it generally shows itself about age 35. There's frequently no great interval between affection of the hands and the feet, both these becoming similar in nature, slender with little flesh. For the most part, the arthritis path is from the feet to the hands, next to the elbows and knees, after this, the hip joint. It is incredible how fast the mischief spreads. So we don't know for sure that was rheumatoid arthritis, but certainly sounds like some autoimmune arthritis going back many, many, many years. And then in more recent history, there was a new arthritis discovered, or at least written about in the 1800s by Dr. Jacob, who described primary aesthetic gout, which they thought was an arthritis different than normal gout. And these were sort of the beginnings descriptions of rheumatoid arthritis. All to say, this condition has been with us for a while, and I think today, fortunately, we have a much better understanding of what causes it and how to treat it than they did back then. So rheumatoid arthritis is actually one of the more common things we treat in rheumatology. It affects up to 1% of the population. It is more common in women, so women are 2 times more likely to get this condition than men. The peak incidence and prevalence when we most often diagnose this is people in the age 60 to 80 years old. But that said, we very commonly do see this in younger patients, and that's a big difference from other types of arthritis. So we'll often see patients who get rheumatoid arthritis first when they're in their 20s or 30 years old. I did want to just take a second before we launch further into the talk to explain a little bit the difference between rheumatoid arthritis and osteoarthritis, just because I think osteoarthritis might be what many in the audience have more commonly heard about. And there's actually a very a lot of big differences between these conditions. So you can see the table I put up on the screen. Rheumatoid arthritis is caused by your immune system being overactive, so it's an autoimmune disease. Whereas osteoarthritis is wear and tear over time, and it's really when we wear down the cartilage, which is the cushion between our bones. So that's when people say they have bone on bone. That's osteoarthritis. So very different causes, and that leads to differences in how you approach them. Rheumatoid arthritis is overall uncommon compared to osteoarthritis, which is very common. When most people say they have arthritis, especially if you think about, your grandparents having arthritis, most commonly they mean osteoarthritis. Rheumatoid arthritis, as we just discussed, can affect younger or older patients, whereas osteoarthritis really tends to affect people in middle age and then getting even more common as you get older. It would be very, very rare to see this in a young patient without something else going on. And then the treatment is very different because the cause is very different. So for rheumatoid arthritis, the treatment is immunosuppression or medications that lower the immune system, whereas osteoarthritis, it's not an autoimmune issue, it's wear and tear, and the treatment is usually physical therapy, pain control, and then sometimes joint replacement, depending on the joint affected or the severity and other different factors. So before we go more into rheumatoid arthritis, I just wanted to do a brief overview of the immune system because it plays a key role. So your immune system is designed to protect your body against threat. So evolutionarily, this was there to protect us mostly from infection, which could be very serious if you didn't have an immune system to fight it off. And then also actually different types of cancers, there's a role of the immune system in kind of preventing the development of cancer, we think. And the immune system is a big term that is referring to many different cell types and even organs such as the skin are, part of your immune system. You can see on the left side of the screen, we have a diagram just trying to show you that there are different cell types. So you can have T cells and B cells. These are all part of your white blood cells. Those are, cells that fight infection. And so what they do is they recognize what is foreign to the body, what shouldn't be there, and then they attack it because they assume that this is a threat. And again, evolutionarily, that was true. An infection is going to look different to your body and you want to get rid of it. But what happens in autoimmune disease is your immune system gets mistaken and it mistakes your own body and your own tissues as foreign and it attacks. And that's what's leading to inflammation where there shouldn't be inflammation. And that's what causes the symptoms of autoimmune disease. So for rheumatoid arthritis in particular, um, there's not one specific cause we've identified, but it's really multifactorial where people might have some genetic susceptibility and higher risk even from the day they're born of getting rheumatoid arthritis, but it doesn't mean they're definitely going to get it. But then things happen over time, like different triggers in the environment, things are exposed to. And over the years, they can develop rheumatoid arthritis. So you see this is outlined in the figure on the screen. Along the top, we have progression over time. So someone might have susceptibility to rheumatoid arthritis. And in fact, there is a genetic component with first-degree relatives. If you have a first-degree relative with rheumatoid arthritis, you're probably 3 times higher risk of having rheumatoid arthritis yourself. So we know that there's some genetic susceptibility. And then at some point, something triggers your immune system to become autoimmune or attacking yourself. And then over time, you'll start to get the symptoms of rheumatoid arthritis. If you look at the bottom half of the figure, that's showing you a diagram of what's happening in the bones and the joints and even with the immune cells to correlate. So on the far left, you have the normal joint. You can see the 2 bones. There's the cartilage, that's the cushion of the bones, the synovium, which is a very small layer of cells. That's all normal joint. And then you start to get immune cells kind of coming into the joint space. And then they're causing issues when they really have a lot of immune cells there. And they cause, overgrowth of tissue and pain and inflammation. So we talked a bit about you have this maybe baseline higher risk of rheumatoid arthritis, and then there's something in the environment that sets you on the path to actually getting rheumatoid arthritis. What are these environmental risk factors? We've identified a couple. Again, there's probably lots of things that can do this. A big one we've seen is cigarette smoking. So especially if you have already the genetic predisposition. If you're a smoker of cigarettes, so there's something in that really makes you higher risk to get rheumatoid arthritis, and you're much higher risk to get it if you are smoking. They've seen similar signals with people who have chronic inflammation in the lungs or in the mouth. Certainly, any infection can kind of trigger this by turning on your immune system, and then it doesn't turn back down. And they have sometimes identified things in the workplace. So, depending on the occupation, you might be exposed to things like silica or solvents or chemical fertilizers. All of these have been identified as potential risk factors for rheumatoid arthritis. So what does rheumatoid arthritis look like? And what does that mean, when you see it in clinic and with a patient? The biggest symptom is joint pain, and this comes with swelling and stiffness. Symptoms are often worse in the morning. That's important because a lot of our other types, like osteoarthritis, that's actually worse at the end of the day when you've been up moving around. But with rheumatoid arthritis and other autoimmune arthritis, often your symptoms are worse in the morning. And so that pattern is very helpful for us as clinicians. Stiffness is a big part of it. And so people will have stiffness and it lasts a long time, like an hour in the morning or more. Some patients will say, they're stiff to midday, the whole day. Again, whereas sort of wear and tear arthritis, you can have stiffness in the morning, but often it's a couple minutes or under half an hour. So this is more prominent. And the symptoms tend to get better throughout the day. Rheumatoid arthritis is a symmetric disease, meaning it affects both sides of the body. And if you see on the left side of the screen, we have a skeleton here, but he's supposed to represent the areas that are often affected by rheumatoid arthritis. And you can see these black dots, the black circles is the joints that would be more likely to be involved. And you see it's affecting both sides of the skeleton equally. And then often it is the small joints, at least where it starts. So it most classically starts in the hands and then it moves to the wrists and the feet. But then over time, of course, people can get involvement of other joints, so the knees, the shoulders, etc. And it can even start as brief episodes of pain. And then on the bottom left, I just have a picture. This would be a severe case of rheumatoid arthritis, but you can see where the arrows are pointing. That's swelling of those joints. So you have rows and knuckles. Those are your joints in the hands. So you can see they're swollen and the fingers are a little bit lower than they should be. And that's because of the joint inflammation and some looseness of the tendons. I just wanted to include this slide as well, again, just to show a little bit more pictures of what rheumatoid arthritis might look like, and then also what's going on under the hood. So if you look on the right side of the screen, this would be a picture that would be something you could see with rheumatoid arthritis. I have the arrows here, but you can see the middle row of joints, which is your middle knuckles. We call these the PIPs, would be the doctor term. Those are swollen, and you can see that in the photo. And on the left side of the screen, I just tried to show what is actually causing that swelling. So if you look at the top left, here's a diagram of a joint. On the left side of the joint is normal, and the right side is the joint with rheumatoid arthritis. And you can see the joint that is abnormal, there's more swelling. You get something called synovial hyperplasia. So that's that lining of cells, the synovium, and the joint gets bigger than it should be. You have a lot of immune cells there when they shouldn't be, and you can get damage to the bone and destruction of the bone. On the bottom left, this is an ultrasound, which is one way we can just look at the structures in a joint. And this is looking at a finger. The bright white lines are the two finger bones. The kind of grayish over the top is the tendon. You can see the top picture is normal. So you have those two white bones. They almost touch on top of the tendon. It kind of sits right on top of the bone. The bottom picture is abnormal. That's a joint that has been affected by rheumatoid arthritis and is very active. And you can see there's all this extra gray material that's coming out of the joint space. That's the synovial lining in the synovium getting bigger. And then the bright colored orange, that's showing extra blood flow, which is a sign of inflammation. And then this picture is showing the stages of rheumatoid arthritis. Of course, in rheumatology, we try to prevent that picture on the far right, which is late rheumatoid arthritis. That would be very active disease that either wasn't controlled for a while or very hard to control. Our goal is to catch people on the left side of the screen, the early rheumatoid arthritis. You can see there's some swelling there, but it's overall more mild, and we try to prevent the progression to the late rheumatoid arthritis. So we focus so far on the joints, and that is important because rheumatoid arthritis most strongly affects the joints or most commonly, but it is really important to recognize that this is a condition that can affect the whole body. And while the joints are, often the thing that bring people into our clinic and their most common symptom, we do have to watch for all other things with rheumatoid arthritis. So it can affect many other organs. The key ones we think about are the eyes, the skin, the lungs, and the heart. So people can get inflammation in the eyes that we have to be careful to treat, get inflammation in the skin, which can show up as skin rashes or ulcers in the skin, inflammation in the lungs that could cause cough or trouble breathing, inflammation in the heart, which could cause, chest pain, other symptoms. These are less common, but again, it is really important that we watch for them. More often, we would be seeing involvement if the condition wasn't well treated. So someone who's on the appropriate medicine and has good control of the joints, it's less likely to see these things. We still think about it, but I'm most worried about this if I see a patient who has really not had good control of their condition yet. I'd be worried about involvement in these other organs. And then you also have conditions that we see that aren't maybe directly rheumatoid arthritis, but they're associated with rheumatoid arthritis, and we see that they come together. So a really important one is increased cardiovascular risk. That means increased risk of heart attack and stroke. We think this is because if there's a lot of uncontrolled inflammation in the body, that's stressful for the body, and that can increase the cardiovascular risk. Similarly, we do see higher rates of depression, chronic pain. Often when the body's been in a lot of pain from inflammation in the joints, it can cause sensitivity to pain in the brain to actually go up because it's getting so many signals about pain elsewhere, and that can lead to chronic pain. There is increased risk of cancer and rheumatoid arthritis, and increased risk of osteoporosis, which is thinning of the bones, which can predispose someone to getting a fracture. So these are all things as a rheumatologist that we're going to be looking out for because we know that this can be associated with rheumatoid arthritis. So how do we diagnose rheumatoid arthritis? There are three kind of main key things. By far the biggest being our history and physical exam. In rheumatology, that's really still extremely important. So that is going to help us the most. We do have labs. We'll talk about these a little bit, but there are some key lab tests that can be very helpful for diagnosing rheumatoid arthritis. And then sometimes we need imaging as well, although I'll say many, many cases we can just diagnose with our history, our physical exam, and the lab work. We don't always need the imaging to get a diagnosis, but it can be helpful for us, A, to see how severe the rheumatoid arthritis is. It can help monitor over time. And sometimes if there's an unclear case, we're not sure what's going on, the imaging can help with the diagnosis itself. So the lab tests, there are two key tests for rheumatoid arthritis. One is called the rheumatoid factor, and one is called the CCP, which you guys, if anyone has rheumatoid arthritis in the audience, they might have heard about these tests. I will say that 50% of patients can have negative testing at the time of diagnosis. And even, years later, 20% can have still negative tests. That's what we call seronegative rheumatoid arthritis, meaning sero is blood, negative, negative. So it's rheumatoid arthritis without the positive blood test. And this is why really our history and our physical exam is the most important because we can diagnose it even with a negative blood test. We also typically get general tests for inflammation. These are called the erythrocyte sedimentation rate, or ESR, and C-reactive protein. These tests don't tell you have rheumatoid arthritis. They're not specific to rheumatoid arthritis. They can actually be high in many different conditions, infection, cancers, and autoimmune disease, but they do tell us that there's inflammation somewhere in the body. So they help us, but not as much as just the rheumatoid arthritis tests. And I will make a note that for the rheumatoid arthritis tests, the RF and the CCP, they're much more helpful at higher levels because they're more likely to be a true positive. especially with the rheumatoid factor. If you see a low level positive that's just a little bit higher than what the lab says is normal, that can very frequently be a false positive. That could be caused by something like a viral infection or, other fluctuation that will turn negative in the future. So that is something we take into consideration when we get the lab tests. And I did want to show you some imaging. Again, we don't always need the imaging to make the diagnosis, but it can be helpful. And this is an X-ray, which is showing sort of a classic picture of rheumatoid arthritis. So you can see the two bones. And so we're looking at the space between the two bones is the joint space. And in this X-ray, you can see the small arrowheads. That's swelling in the tissue, that kind of brighter, it's still gray, but the brighter gray, that's soft tissue swelling. And the full arrow is pointing to something called an erosion, which is a little bit of damage in the bone. And you can see there's a divot in the bone where that arrow is. And that is a classic finding in rheumatoid arthritis. This is the classification criteria for rheumatoid arthritis. So this is produced by two of our big kind of guiding bodies, the American College of Rheumatology and the European League Against Rheumatism. We definitely don't need to go through everything. It's a busy slide. I just wanted to highlight the key features of how you might, classify someone with rheumatoid arthritis. So they have joint involvement, symptoms. Symptoms should really be more than 6 weeks. If it's under 6 weeks, that could be something else entirely. It could be an infection. It might go away with time. So that's why we like to see that it's actually lasted more than 3 weeks. You can see the labs do give you points, and then elevated inflammatory markers can give you points. So this is a helpful framework for rheumatoid arthritis. As a clinician, we can have a high suspicion that someone has rheumatoid arthritis, even if they don't get all of these points. So it doesn't mean we won't treat if they don't, get all of the points, but it's a helpful framework when you're trying to think, does this patient have rheumatoid arthritis or a different condition? So now we'll pivot to treatment of rheumatoid arthritis, where I wanted to, leave some time at the end for this as well. So there are two key principles for treatment of rheumatoid arthritis. One is early identification of the disease, and the second is something called treat to target. So we're going to talk about both of these. So early identification is very important because if we don't catch the inflammation, that can lead to problems that can't be reversed. So if we have uncontrolled inflammation, so like those photos I showed you with all the extra blood flow, all the immune cells, all the swelling, over time, that can lead to joint damage and bone erosion. And they've had studies looking at how fast this happens. One was a study of 42 patients with rheumatoid arthritis, and they found that even in less than 2 years, so pretty early into a patient having rheumatoid arthritis, 80% had joint space narrowing, which is a sign of, there's been damage in the joint space narrowing. And then 66 had actual joint erosion. So that's like the X-ray I showed you guys where there's actually a little piece of the bone that's been eaten away. And that happened pretty quickly within 2 years. So as rheumatologists, we want to find this inflammation and we want to see these patients in our clinic so that we can get the inflammation under control before you get the joint damage. So if it's just inflammation, we can reverse it with our medications. But if we're seeing damage to the bones, like the joint space narrowing or the erosions in the bones, we can't undo that with our medication. We can try to prevent it from getting worse, but we can't really reverse the erosions and the damage in the bone and the joint. So that's our whole goal is if we meet someone when they're in the top photo, the top right, we see that there's swelling, there's inflammation, but our job is to stop it before we get to the photo in the bottom where there's more chronic changes that will be hard to reverse. The other reason why early identification and treatment is important is there is this idea that there's a window of treatment with rheumatoid arthritis, in that some studies have shown that if you treat a patient more aggressively within the first year, you're more likely to get disease control and better disease control than if you wait and treat them later. And again, it doesn't have to be an emergency that has to happen overnight, but you really do want to get them earlier in the treatment course so that you can be more aggressive about starting medications and getting things under control. The second principle that I wanted to review is something called treat to target. And this you can think of as a guiding strategy for how we treat rheumatoid arthritis. And it's really the idea is to keep you on track with your improvement. So there are 4 steps. You identify a disease target. We'll talk about this in the next slide, but that's your where you want to go. And you set a goal, and the goal could be remission, which is, things are all the way no symptoms or low disease activity. And then you measure the disease activity regularly to assess whether patients have achieved that target. And then if not, you adjust the treatments if patients are not at target. So just to talk a little bit more closely about where our goal is, we have 2 possibilities. One, which would be best if you can get there, is remission. So that's inactive disease. You're not having symptoms. Also acceptable is low disease activity, and that's a state that keeps the symptoms under good control and you're maintaining a good quality of life. So the symptoms might not be absolutely 0, but they're very mild and they're not impairing your day-to-day activity. And this is a diagram just to outline treat to target. Again, you identify a target for a patient. This is saying DAS28. That's just a disease activity score. We'll go a little bit into that, but I don't think the specifics are so important. But that is just saying, where do we want to go? What's our goal? Which is probably remission to low disease activity. And then you want to follow up, and have a set follow-up. Usually it's 3 months. And at that time, you want to know if you've reached your target. If it has, great. If you haven't, then you need to revisit the drawing board and add something or change something. And I know that this seems, in some sense, like common sense, but actually it's been shown that really being strict about this strategy is associated with better outcomes. To quickly touch on the disease activity scores, again, there are many of them. A lot of them are used in clinical trials. I don't think we need to know the specifics of them. But just the general idea is you're taking into account several variables. So one is the exam. So, your doctor will look at your joints. Do they look swollen? Are they tender? That's going to be important. Obviously, the patient perspective is extremely important. So we want to hear from our patients, how do they feel their disease is going? How do they feel their symptoms are? And then, of course, we'll have, an opinion as a provider based on everything we're seeing, how we think the control is. And you can add some labs into these disease activity scores. So the ones that we talked about that mark inflammation, the ESR and the CRP can go up and down, with flares of disease. So those can be helpful too. I did want to cover this trial. I thought this was really interesting, again, just to emphasize the importance of this strategy. So this was a single-blind randomized controlled trial, and this is looking at the effect of a treatment strategy of tight control for rheumatoid arthritis. And a randomized controlled trial is like our highest level of data as doctors. So we use all sorts of things to guide how we treat patients, what we've learned in med school, what we know about anatomy, et cetera. But the clinical trials are really the most helpful because those are showing we gave a bunch of patients a treatment, other patients we gave a different treatment, and we just see which one worked better. And so it gives us a really good answer. So for this trial, what they did is they had an intensive group and a routine group. The intensive group had actually even a monthly visit, which is really, really frequent. And at each visit, they calculated one of these disease activity scores. And at 3 months, if it was high, they made sure to adjust treatment. The routine group was sort of usual care and clinic. They came every 3 months. And I think the big difference is they didn't technically use these specific scores or a specific reason to up titrate therapy. It was really based on the doctor's discretion who was treating them. So it was just less standardized. Obviously, if they saw a lot of swelling and pain on exam, that's often a reason you would go up on immunosuppression, but it wasn't as strictly protocoled, and they didn't use any of the formal disease activity scores. And you can see on the right side of the screen, so that's looking at the outcome of this trial. And so you can see the line on the bottom with the dark diamonds, that's the intensive group, and the white squares on top is routine. And you can see on the y-axis, that's disease activity. So the group that had the more intensive treatment, that line goes down faster and it goes down lower, and that's good. You're seeing that the disease activity went down faster and stayed lower. So even though it seems a bit like common sense, it is really helpful to keep this framework that you really want tight disease control, and that will help you get lower disease activity. I will note, even though they had a monthly visit in the intensive group, they only changed therapy at 3 months. That's because all of our meds, or most of them, take usually around 3 months to see if they're working. So you wouldn't want to be changing them every month because you haven't seen if it worked yet. They could get things like steroid injections and other things like that at the monthly visit. A word of caution with treat to target. So I know I just talked about how this is the best strategy, and it is, and it's our guiding principle. But that said, we do need to use our clinical judgment. It is important to keep in mind that there are many coexisting conditions that can affect these disease activity scores. Because if you recall, a lot of them are about tenderness on exam, so pain when your doctor is pressing, or just pain the patient's having. But there are a lot of things that cause pain, and it's not always inflammation. So people can have chronic pain. Again, we saw that that's associated with rheumatoid arthritis. Things like fibromyalgia, which is common with rheumatoid arthritis, osteoarthritis, which is common in general, and irreversible joint damage. All of those things can cause pain, and those could make the score like a little confusing to interpret. But all those conditions, they don't get better with lowering the immune system, immunosuppression. So you really do have to weigh the risk benefit because our medications do have side effects, and we use them when we need to, but we have to be cautious that what we're treating is actually going to get better with the medicine. Otherwise, we're starting a medicine that can actually cause dangerous things for our patients without any chance of benefit. So you do have to take the disease scores into kind of clinical context and think about what could be causing the score to be high. So what are our treatment options for rheumatoid arthritis? The good news is we have many, many treatment options. So we have a lot of ways to get patients feeling better. There are three main types. There's the traditional disease-modifying antirheumatic drugs. We call those DMARDs. These are like our tried and true, have been around many, 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 many years. We have lots of practice with these medications. And then I feel I'm very lucky to be practicing at a time when we've had newer medicines come out, and these are the second two classes. So we have biologic disease-modifying drugs, or BDMARDs. These are proteins or monoclonal antibodies. And I think the important thing to know is they're sort of targeting specific targets in the immune system, so cells or the immune kind of communication, which is a cytokine. And then there's targeted synthetic DMARDs, and these are small molecules. They're also a bit more specific, and they're looking at specific immune signaling pathways, which is how the immune system talks to itself and to the other cells. So we use all three of these. For short-term treatment, the only thing that is really challenging is all of these. So DMARDs, biologic DMARDs, targeted synthetic DMARDs, they all take time to work. So I always tell my patients rule of thumb is about 3 months. Sometimes people get lucky and they start noticing improvement within a couple of weeks. I love when that happens, but it's not always the case. Often it's 3 months. And then some patients, like, they keep getting benefit even 4 months, 6 months into a medication. So we have a lot of options, but I think the tricky thing is a lot of times people are in a lot of pain and none of these work overnight. So what do we use for short term? We use a lot of glucocorticoid medications. We love them in some sense because they tend to work extremely well. These actually will work almost overnight, or at least over a couple days. However, they're a double-edged sword because they have a lot of side effects. So even though we like them because they work well, we really try to limit them as best we can. The way we limit them is we try to do the lowest dose we can get away with. So the lowest dose that will control the pain and the swelling, that's what we want. And then we try to not keep them on for a long time. Like usually, if someone's having a flare, maybe a couple of weeks, but we really try to avoid keeping these on for a long time because of all the side effects. And you guys can see them on the screen, but there's trouble sleeping, irritability, weight gain, high blood sugar, which can over time predispose to diabetes, or if you have diabetes, it can make it really hard to control, can cause high blood pressure, thinning of the bones, which can lead to fractures down the road, increased infection risk, cataracts. And this is honestly like a small list. There are even more. So while we love them in some ways, we try really to limit how much we use these medications. So for our traditional DMARDs, our main ones are methotrexate, hydroxychloroquine, sulfasalazine, leflunomide. These are almost all more oral medications, but methotrexate in particular can be in injection form as well. They all lower the immune system. So that means that you are at increased risk for infection if you're on these medications. It's overall mild. And I will note that hydroxychloroquine is the exception to that rule. So it does not increase your infection risk at all. So that's actually a great medicine. If you're worried about infection, you can still start hydroxychloroquine. All of our meds, it is important that we monitor labs on the medication. So we're looking at things like your cell counts, your kidney numbers, your liver numbers to make sure that the medicine's agreeing with your body and that we're not seeing any issue with any organ when you're on the medicine. And then we get to our newer medications. So these are the biologics and the targeted synthetic DMARDs. You can see on the right side of the screen, I have a graph that's, very complicated. We're not going to go through everything, but I just wanted to show that these medications work at all different parts of the immune system. So you can see all the different immune cells talking to each other and signaling to each other. And the biologics and the targeted synthetic DMARDs, they target different parts of these pathways and they kind of knock them out, and that helps lower the immune system. The one type of them, the JAK inhibitors, are oral medications, but all the others tend to be injection or infusion medications. And you take them less frequently. It depends which one you pick, anywhere from once a week to once every 6 months. They also lower the immune system, often a bit more than the other ones, and they also need lab monitoring. The general approach for treatment of rheumatoid arthritis is really from our American College of Rheumatology guidelines. So again, this is our sort of leading body that looks at all the evidence, all the clinical trials, and they meet and they basically take all the smartest people who study rheumatoid arthritis, they put them in a room and they do, they do lots of review of all the literature out there and they come up with these guidelines to help us. And that way we make sure we're giving standardized care to our patients. So if you have low disease activity, that means you have mild rheumatoid arthritis. You can start with hydroxychloroquine. That's a great situation because, again, that one that doesn't lower the immune system. It's a pill. It's overall well tolerated. So we can do that if you have very mild disease. However, I would say a lot of patients, when we meet them, they really have moderate to high disease activity. Hydroxychloroquine is not going to be enough. And so you should start with methotrexate. Methotrexate we love because it's well tolerated, it's safe, we've been using it for years, and it's low cost. If methotrexate alone isn't effective, then we add some of these newer medications like the biologics. And it is just important to note, let's say you're on methotrexate, you're on a biologic, and it's not working for you. For your next choice, you would pick a medicine from a different class. So if you were on, let's say, a TNF inhibitor and it wasn't working, I would pick a different medicine, not a TNF inhibitor. If you had, some effect before and you lost it, it can be a subtle decision. But if you had no improvement, you really probably want to try a different class of medication. For rheumatoid arthritis and pregnancy, I did want to take time to talk about this because, again, a lot of our patients are young women. And so this is something that comes up not infrequently. And we actually have a lot of experience in rheumatology treating people throughout pregnancy. And we have a lot of different options. So actually, about half of women have improvement during pregnancy. And really, some of the estimates even go up higher than half, but I would say at least rule of thumb, 50%. So that's great. But if that's not the case and you're not one of the lucky women who improved during pregnancy, then there are many medications that we can use. So hydroxychloroquine is safe in pregnancy, sulfasalazine is safe, TNF inhibitors are safe in pregnancy. Depending on the clinical scenario, you may stop them in the third trimester, but it's actually a decision between you and your doctor and depends on many factors and how bad the disease is. And so sometimes you actually use them throughout the third trimester. And other autoimmune conditions, you have to do that. It's too dangerous to stop them, and it goes totally fine. The flip side, so while it's great that a lot of women get better during pregnancy, there is higher risk of flare in the postpartum period. So if you do have rheumatoid arthritis and you give birth, in the weeks to months after giving birth, you do need to watch out for flare of your symptoms. And they have also seen for people who don't have rheumatoid arthritis, that's actually one period that they will see like women get diagnosed with new rheumatoid arthritis in the postpartum period as well. So beyond medications, what else can patients do to help themselves if they have rheumatoid arthritis? Because this is a question I get all the time in clinic. One big thing is to stay on top of regular appointments. So we just went through all the treat to target. that's the responsibility of your doctor to be seeing you regularly, but it's also important for you as a patient to come to your appointments regularly so we can get things under control. And the routine labs, again, these roughly every 3 months, depends exactly on the patient and the medication, but that's something you should be thinking of. Most of our medications, we don't want you to go 2 years without getting a lab test. We want to make sure you're tolerating the medication okay. It's very important to get your vaccines. Our medications lower the immune system, so our patients are at higher risk for severe infection. So even if someone else gets the flu and they're fine, that might not be the case if you're on, let's say, rituximab. And so it's really important that we just optimize the risk-benefit ratio of our medicines. And the way you can do this is get your vaccines. Um, it is important that you talk to your doctor before getting a live vaccine because this can be very dangerous if you're on immunosuppressive medicine. So there are two types of vaccines. There's the non-live or inactive vaccine. That one's fine. But there are live vaccines, things like yellow fever or the measles vaccine has come up a lot recently. It's a live vaccine, so you don't want to just go to CVS and get it. They might not realize, that it's a more nuanced decision. You need to message your doctor, talk to the nurses, and ask them if it's okay to get the medicine. Often we'll come up with a plan about what's safe. It might mean holding off your medication or, it'll depend in talking to your doctor, but that's an important note. And then healthy diet. So we know that the Mediterranean diet lowers the risk of heart attack and stroke, and there's actually very good data for this. So that's important because as we talked about, patients with rheumatoid arthritis have increased risk of heart attack and stroke. So you should be doing everything you can to lower this risk. Everyone really should be, regardless. And so the Mediterranean diet is the best diet to lower the risk of these things. And then there's more limited data that anti-inflammatory diet can reduce joint pain, and we'll talk a little bit more about that in the coming slides. And then regular exercise is important. This helps prevent frailty and reduces pain. And I kind of think of it as sort of like anti-inflammatory as well. It's really good for your body. And so as much as you can, of course, if someone's having a flare of their rheumatoid arthritis or in tons of pain, they might not be able to, get up and go for a run. You do need to listen to your body. But if things are well controlled, even just starting walking daily, trying to get your 30 minutes of walking 5 times a week, these things all help. And then regular sleep, trying to get enough hours of sleep. We try to shoot for 8, can depend a little bit on the person, but making sure that you're sleeping well will help. Oh, and stop smoking. We talked about it. So smoking is important in that it increases your risk of getting rheumatoid arthritis, but also if you have rheumatoid arthritis, if you're smoking, it's harder to get the disease under control. So please stop smoking. And we can help as your rheumatologist, your primary care doctor can help. We have lots of medications to help with this. I thought people might want to hear about diets. I think it's something that my patients, at least in my experience, have questions about. So this is the itis diet. So this is specifically in patients with rheumatoid arthritis, actually. And this was sort of came out of research from University of San Diego, one of the rheumatologists there. It's a very California diet if you think about it. There's like green juice and veggies. But I have on the screen the do's and the don'ts. It is very similar to the Mediterranean diet. So if you want an easy way to think about it, it's essentially the Mediterranean diet with a couple different things. So you want to be doing mostly fish. So your protein, fatty fish, white fish, or like white meat, like poultry. You want to avoid tons of red meat or processed meat. You want to avoid flour, refined flour, soda, juices, extra sugar. And you want to get more like nuts, chia, whole grains, so things like quinoa or farro. They do have turmeric. That is a question that I get a lot. I think there is some data to show that turmeric can be helpful. You have to be very careful ordering like supplements off Amazon because we don't know what's in them. But if you want to use it for your cooking, that's probably the better way to get it into your diet. And then you do see on the right side, the don'ts for the itis diet. They do mention eggplant, tomatoes, potatoes. I would say in general, those are healthy foods. And those would be fine for a kind of Mediterranean diet, but I think they worry perhaps this particular itis diet that they can increase inflammation. But I would say in general, if you like those things, I still think they're healthy. And this is a small study, so I don't think you have to completely get rid of it. Everything in moderation. And then this is just the data from the itis diet that I wanted to show you. So again, this is a really small study. So I would not take this as like 100% you must do this, but I did think it was interesting. So what they did in the study is they took patients with rheumatoid arthritis and they had them for 2 weeks go on the itis diet. Um, and you can see, so on the right side of the screen, the four different graphs, they're looking at different markers of disease activity essentially. So the top left is just the patient's pain. On the top right, that's the patient's tender joints. And then on the bottom, two, those are both different disease activity scores. And they looked at how people did from the beginning and then how they were doing 14 days later. So these are paired samples, meaning they like looked at one person's pain on day 1 and then on day 14 after doing the diet. And they did find for all of these measures that the pain went down. So there is some suggestion that this itis diet really is helpful. That said, they only had about 20 people, so you really have to take it with a grain of salt. For our clinical trials, we really like, at more than 20 for sure. The bigger the trial, the more you can trust it often. I did see when I was creating this talk, I looked to see if they published any more information, but it's hopefully coming out soon. I think they said that they're finishing the kind of the trial, the bigger trial in 2025. So maybe next year, the year after, we'll have a paper that tells us if they saw this in a bigger group of people. And can you come off rheumatoid arthritis medications? So the short answer is our recommendation is to continue medication, but it is individualized because each patient has different values and different medical conditions, and maybe for them it is the right choice. So it's very individualized. You should certainly talk to your doctor about it. Ideally, you would keep on one medication because there's a very high risk of flare if you stop all your medications, about 50%, and it can be hard to get control once you stop them. So even a medicine that worked before might not work again, and you can be in a tough situation. I would want you to wait at least 6 months before starting to taper. And then it's really better to try to just go down on a dose. So let's say you're on methotrexate 25, go to 20. That's probably the best approach. If you do want to stop everything, it's better to do it gradually than to just stop it all at once. And then I just will end quickly with some of the newer kind of future directions for, I think, rheumatology in general and how it applies to rheumatoid arthritis. So you guys may have seen, actually, it was recently an article in the New York Times for lupus, but there's been a lot of buzz about something called chimeric antigen receptor T cell therapy, or CAR T. This is a totally novel approach to how we treat autoimmune diseases, so it's very cool. You can think of it as a reset to the immune system, and you're training your own cells. So they actually take your own immune cells, they train them in the lab to fight the bad actor. So they initially did this in cancer and they used them to fight cancer cells. But what we're using in autoimmune disease is we're using them to fight the immune cells that are being overactive. And so they train your cells, they put them back in your body, and that's the CAR T cells. And then they kind of get rid of the bad actors in the immune system. So it's very promising, but it's very, very new. So we do not have data on a large amount of patients. And it's not a walk in the park to get this done. And so there are certainly complications that can happen during this whole process. So that's one point of caution. And we don't have good long-term outcomes. And we don't have studies of this in like thousands of patients. So it's hard for us to estimate the risk of the procedure. And it's a little bit hard to know like how long does this provide relief for. In rheumatoid arthritis in particular, there was actually just recently this year in 2025 a case report looking at a patient with rheumatoid arthritis who did get this. It was CD19, that refers to the cell that's being targeted for rheumatoid arthritis. And this poor patient had been on everything. I didn't put it on the slide, but like all the biologics, every medicine, and was having really bad disease. So they did give her CAR T, and she's been in remission off of medications at least 100 days out from the therapy. And I put on the screen their graphs. So you can see the two graphs are looking at, the middle one's looking at disease activity, two different measures of disease activity, and both of those went down after getting the CAR T therapy. And then the far right, those two blood tests we talked about, the rheumatoid arthritis blood tests, the ACPA or CCP and rheumatoid factor, and those both went down after getting the therapy. In the left, this is showing a photo of her tendon. The top one's very abnormal. There's fluid where there shouldn't be. There's that extra blood flow signal, the red. And the bottom one is after the CAR T. You can see the inflammation has gone away. That said, this patient did have complications from the treatment. although no lasting damage from the treatment. So you can get different symptoms, like neurological symptoms with the treatment, which she did get, but that didn't stick with her. They were able to treat it and she got better. So some conclusions: rheumatoid arthritis is a chronic autoimmune disease which causes inflammation in the joints and other organs. It is diagnosed through patient history, physical exam, lab tests, and imaging. Our goal is low disease activity or remission, and we have many medications to help us achieve this goal. So I'm happy to take any questions. I saw the chat had some comments in it. I think Amy was going to help moderate.
Thank you so much, Dr. Parsons. We are now at the end of this presentation. If you have any questions, feel free to enter them in the chat. And I believe Dr. Bolster was going to help moderate and ask the questions today.
That would be great. I would first like to thank Dr. Parsons for such an excellent presentation. Really covered a lot of territory and I think answered some of the questions that came through the chat, maybe anticipating things that people would want to hear about, which is just wonderful. There are a lot of questions in the chat, so I'm going to try to move through them as best we can, but I want to make sure we leave time for Dr. Parsons to address them. So there were several questions that related to rheumatoid arthritis and osteoarthritis. And so I guess I would just pose the question, in a patient who has rheumatoid arthritis, would you expect the treatment for the rheumatoid arthritis to help the osteoarthritis? And if not, then how would you in general approach the osteoarthritis component?
That's a great question. And I think that's actually something we run into a clinic a lot, where we get the rheumatoid arthritis under control. And no, I don't typically think of our rheumatoid arthritis meds as helping the osteoarthritis very much. There's some data for some of our medications, like hydroxychloroquine and methotrexate, can be used sort of off-label for osteoarthritis, especially in the hands. But it really is a pretty different treatment pathway. And so if I had a patient I felt like their rheumatoid arthritis was well controlled based on the characteristics of the pain when I asked them about it in my exam, the way I would treat their osteoarthritis is pretty different. So it would be more physical therapy. There's actually really good data for physical therapy and osteoarthritis, especially in the knee. We're actually getting a lot more data newer about the weight loss medicines that everyone's been hearing about. Actually, are having some data showing that they're helpful for osteoarthritis, and that can be considered. And then depending on the joint, I would refer my patient to orthopedics if it's like a hip or a knee, something to be replaced. But they are pretty different treatment pathways, so I would think of them differently.
Okay, very helpful. And you mentioned the tobacco use as being a risk factor for developing rheumatoid arthritis. I don't know if you can comment on secondhand smoke exposure, if there's any.
Good question. I think that I don't think there's as strong a link between them, is my understanding, Dr. Bolster. I don't know if you have heard otherwise, but I think it's more if you are actually doing this, like inhaling the smoke from a cigarette.
Right. I think that we would certainly want to minimize secondhand smoke if possible, but I don't think that the data are as strong as for personal use of tobacco. Is seronegative RA, you talked about that, is that treated any differently than seropositive RA?
So we use a lot of the same medications for seronegative RA. I would say one of the things I think about with seronegative RA when I have a patient with it is I am sort of on the lookout just to make sure I'm not missing another condition. It can be confusing because, of course, seronegative means we don't have the blood test to, really the positive RF or the positive CCP. And so in the back of my head, I think about if that patient could have a different autoimmune arthritis, like a psoriatic arthritis, for example, or, we have different types of autoimmune arthritis. So I think I keep that in the back of my head. But the medications, like a lot of the medications that work for seropositive rheumatoid arthritis are going to work for seronegative. So you can use the same types of treatments.
And if a patient is treated early for rheumatoid arthritis, can they expect to have no joint damage or disfiguring changes ever?
Yeah, I would say so. In medicine, we never say 100%. It's just how we are. But I would say if you get your rheumatoid arthritis under good control quickly, and an exam, you're not having tons of pain or swelling, and you and your doctor feel together, you've met, your disease activity target. That is very helpful to prevent joint damage. I think it can be tricky. Sometimes people feel okay, and it is still possible if you monitor x-rays over time. You might still see a little bit of joint damage over time, but you're certainly going to make it much less likely to happen. And I think you're much less likely to progress to those kind of photos I showed in the slide where people have really chronic damage. That I think is unlikely if you're well treated.
And do you have individualized treatment plans for each patient?
Yes, absolutely. I think we have a lot of medications that we know work and work well. And so often if it's one patient, I might start in the same place for a lot of my patients, but it depends how they respond to the medicine. If they have other medical conditions, that maybe makes that medicine not a good idea for them, but it could be a good idea for someone else. So certainly.
And we just have a few more minutes. There are several questions related to diet and pregnancy, but I think you addressed those pretty well in your presentation. There were a few questions also about fatigue. And is that a common symptom of rheumatoid arthritis? And with treatment, should we expect for the fatigue to go away?
Yeah, I think fatigue is common. Certainly if you're in the middle of a flare and you have high levels of inflammation in the body, you can feel sort of under the weather. And treating the flare and treating the active inflammation will help the fatigue. I do think it can be challenging there in rheumatoid arthritis and other autoimmune disease. Sometimes you do get overlap of things like fibromyalgia that might persist a little bit beyond even once you've controlled the inflammation. And so I think step one is making sure you've actually controlled the inflammation well. And that's again based on the labs, on the physical exam, patient symptoms. If you feel like you've controlled the inflammation well and there's still fatigue, that might be a little bit of persistent. There can be overlap with fibromyalgia. Often slowly reintroducing exercise is going to help people get their energy back. And I'm always looking again for other things like, is there sleep apnea or something completely unrelated to rheumatoid arthritis that's causing fatigue? So I usually ask them to work with their primary care doctor to make sure we're not missing something else.
There were a lot of questions to help people differentiate rheumatoid arthritis from gout, ankylosing spondylitis, and pseudogout. So I wonder if you can maybe comment if you think of rheumatoid arthritis as encompassing those diseases or if they're specifically different.
Yeah, so they are very different. So rheumatoid arthritis is different than gout or pseudogout. Gout and pseudogout are similar, but they're still different. I think about those as crystalline diseases. And there are a couple ways that you can try to figure out what is what. There's a blood test for gout, a uric acid. If that's high, that might give you a hint. Really, the best way is to, if you have a swollen joint, actually take the fluid out of the joint and look under the microscope, and you can see if there's crystals. So I would really try to do the diagnostics to look at the differences, and imaging can help you too, because they're treated differently. And so you do want to distinguish rheumatoid arthritis from gout, which is caused by crystal, CPPD, or pseudogout, it's called by a crystal. And then I think you mentioned spondyloarthropathy or angst. That's a different type of autoimmune arthritis that is different than rheumatoid arthritis. It's similar in that it's an autoimmune cause. However, it's a little bit different in the joints that it affects. There's some overlapping medicines that will treat both, but some medicines are really better for spondyloarthropathy. And so your doctor can distinguish between the two with imaging, potentially with blood tests. And sometimes it's really tricky. If you have like a seronegative rheumatoid arthritis where the blood tests are negative and it's kind of affecting similar joints, that could be a spondyloarthropathy. Often we discover it over time and that we try medicines that we think would work for both. But if you're pushed to pick one, you see how the patient does. It can be challenging.
Fantastic answers to conclude a fantastic talk. We did not get to all the questions. There were lots and lots of questions. And I would just say that for those of I didn't maybe mention some of the questions that came up that were specific to people's conditions who have RA. And I would suggest that you bring those questions to your physician. Amy, I turn it back over to you.
Thank you. Thank you so much, Dr. Parsons and Dr. Bolster. This is all excellent. I did put in the chat the website address to view the recording. It's going to be on our Blum Center website. I would say give it about 2 to 3 weeks. If you go on that link, click on it, scroll down to view all Blum Center programs on YouTube. That will direct you to the other recordings. All right, everyone. Thank you so much and have a lovely rest of the day.
Thank you.
Take care.
Thanks for having us.